My name is Nthabiseng Phaladze. I'm with Aster Tsegaye. Her internet is a bit unstable right now, but she can chip in anytime. Aster, you are here, right?
Yes, I'm here.
So we only have, to the presenters, we only have you have 5 minutes each. So can somebody help me moderate the time so that we go right ahead? And I see Alemseged. Are you ready to start? According to my list, you are number 3, but I don't see Ebenezer and Felix. So if you are ready, go right ahead. Introduce yourself briefly and then start. Thank you.
Okay, thank you so much. I am Alemseged. I work at Japaigo as a senior capacity building / medical education advisor. So my presentation is entitled Crossing the Regulatory Chasm. Can you hear me, Phaladze?
Yes, we can hear you.
Can hear you.
Yes, we can hear you.
Thank you. So the title of my poster is Crossing the Regulatory Chasm, Implementing Program Accreditation here in Ethiopia. So as you all know, it's a well-established fact that accreditation improves quality of health professions education. However, we're not able to implement program accreditation here in Ethiopia, in part owing to the limited capacity and autonomy of our regulatory agency, which is named Higher Education Relevance and Quality Agency. Our Health Workforce Improvement Program, led by Japaigo, USAID funded, is supporting the government to establish a robust system of accreditation because we want to make put Ethiopia on the global map of accredited medical. So what we did was we did a high-level advocacy with primary stakeholders, higher officials working in the Ministries of Health and Ministry of Science and Higher Education, as well as in higher education institutions. Another thing we did was we did a pause and reflect session with key stakeholders as to find out, the challenge of, implementing accreditation and how to go about it. So after reaching a consensus to kind of initiate this initiative, the accreditation initiative, we helped develop an implementation guide with accreditation standards for about 4 of the cadres, medicine, health office, medicine, nursing, midwifery, and anesthesia. And we also established national technical committees, and there is already a human resource for health steering committee, which provides oversight to this initiative. So we kind of managed this HRH steering committee, high level, led by state ministers and project directors from partners, to kind of see it as, a primary agenda. So what happened as a result was we established an accreditation secretariat at the regulatory agency. We managed to put professional associations up front. We made them sign an MOU with HERCA to provide technical assistance to implement the accreditation. I'm losing the screen.
Yeah, you just go ahead because there's no time while you are working on the screen.
All right. So
yeah.
We managed to enroll 14 programs, 5 medicine, 3 programs each from nursing, midwifery, and anesthesia. And they have conducted right now, as I speak, self-assessment. And we also were able to train around 24 educators to serve as peer assessors for the external review. So what we learned from this initiative and this endeavor is structured pause and reflex sessions help identify critical bottlenecks and come up with practical solutions. The other thing is sustained advocacy is needed at all levels to get buy-in and maximize stakeholder engagement to push through a program accreditation initiative. The other thing we are trying to do is we are trying to get our agency internationally recognized by the World Federation of Medical Education so that higher education institutions would be motivated to get accredited, and the national accreditation easily translates to a global or international accreditation, as there is a lot of push globally and regionally to have comparable programs and competent graduates for 21st century healthcare needs. Thank you.
Thank you. Alima, I'll just go to the next one and then we'll summarize, Aster and I will summarize at the end. If you don't mind, if we are all agreeable.
Okay, yes, that's fine.
We are going to have the next presenter. We have Tasew, no? Yeah, Asselef, can you have? And then after Asselef is going to be.
Yes.
Okay, go ahead, show your presentation. Introduce yourself briefly and go ahead.
Okay, thank you. Good afternoon, all. I am Asselef Tasew from Japaigo, Senior Capacity Building Advisor.
Go ahead.
Oh, I lost.
Okay, you can continue, Asselef.
Okay, thank you. My poster title is Investment to Address Health Professionals Education in Ethiopia. The background is despite significant progress towards achieving gender equity, females remain underrepresented at all levels of higher education in Ethiopia. The share of women in undergraduate, master's, PhD, and leadership and academic position low as compared to the male counterparts. Proactive interventions are needed to achieve gender equity in health profession education and increase women's share in the growing health workforce. A 5-year USAID funded health workforce improvement program supports 57 higher education institutions with the aim of reducing gender disparity in health profession education, retention, graduation, and promotion at supported higher education institutions. Major intervention areas of the project are building academic leaders' capacity to enable them implement and reinforce existing gender equitable policies and strengthening the response to sexual harassment. Tracking changes in educators and students' gender knowledge, attitude, and practice. Also the other intervention areas, and expanding gender transformative activities by sensitizing and building staff and leadership capacity to integrate gender issues in all aspects of programs and interventions and promoting female to leadership position. The other intervention areas are institutionalized gender office by advocating gender office structure and internal budget and resource and space for gender office. When we come to the key accomplishment in the last 1 year, the first one is gender analysis and audit conducted in 54 targeted higher education institutions, and gender gaps identified in student performance and retention, faculty recruitment and promotion, and appointment in leadership position. Findings of the analysis help to set, target, and design tailored interventions that will contribute to female equalities. The result also disseminated to major stakeholders like Ministry of Health, Ministry of Science and Higher Education, and professional associations, and Ministry of Children and Women Affairs. The second accomplishment is higher education institutions and key stakeholders supported to conduct pause and reflect sessions, and the pause and reflect sessions enabled them to reflect on gender office role, evaluate their success, and identify challenges and inform future interventions. The capacity of gender office was also enhanced. To strengthen gender transformative activities, life skill training of trainers was provided to 38 gender focal persons delegated from 38 training institutions to empower teachers and relevant others on the learning needs of female students. Gender responsive pedagogy training of trainers was provided to 38 training institutions, and these two training of trainers were cascaded in each higher education institutions. The other one is on-site coaching was conducted almost in all supported higher education institutions, and this enabled the gender office to strengthen the gender club, peer support groups, and tutorial sessions. Different gender office institutionalization advocacy sessions was also held. As a result of this, 8 higher education institutions assigned gender focal person, 6 higher education institutions integrated gender office into their organogram, and 4 higher education institutions appointed gender focal person as female faculty in leadership position. The way forward, 1, to achieve gender equality in higher education, gender-focused interventions should be integrated into all policies and programs at national level. The second one, for gender equitable policies to be actionable, academic leaders need to be included from the beginning and held accountable for their actions. Thank you.
Thank you, Asselef, for the presentation. Can we note our questions so that we then have enough time to discuss, if you don't mind?
Thank you.
Okay. Okay. Then we can also have the next presentation by Egal. Is Egal here? Ali, Jama Ali.
Jama? Yes, yes, I'm here.
Okay. Because we have, we'll make time for discussion because we don't have the other presenters yet.
Okay. Can I share screen or?
Can you
Yeah.
unshare so that we Jama can share?
Yes. Who is sharing the slide? Okay, it's coming. Okay, can you see it all?
Yes, we can see it.
Great. Okay, I'll get started. Thank you so much for having me here today. My name is Jama Egal. I work at the University of Hargeisa, and I'm the lead for the midwifery department of the College of Medicine and Health Sciences. The title of our abstract was the transfer of a health professionals education course to local partners in Somaliland. Just to give you a brief overview about Somaliland, you can see a map in my poster. And Somaliland was a British protectorate from 1884 to 1960. On the 26th of June 1960, Somaliland became independent and soon joined Somalia as two countries that joined forces. In 1988, Somalia's dictator Siad Barre started war against the people of Somaliland, and more than 55,000 people died. Since 1991, Somaliland has been safe and separate country from Somalia, yet not recognized by the international community. And so to start, I'll give you a brief introduction, which is to start with the way that the initiative has started. In 2017, the University of Hargeisa, Edna Aden University and Ahmad University, together with King's College London, THET and Medicine Africa, were successfully awarded a 5-year grant from UK8 as part of the Strategic Partnership for Higher Education, Innovation and Reform. So the Prepared for Practice program was then developed, with the major element being a certified diploma, certificate diploma and masters in health education, health professionals education program. This was a direct need identified and planned with the Somaliland universities. And so despite the COVID pandemic causing a lot of disruptions with, as you can imagine, visits and travel, Ahmad University managed to deliver the first 3 modules to 30 staff members on their own, and the University of Hargeisa has delivered the first and second modules to 28 participants. And this initiative was obviously led by the amazing graduates that King's has that have graduated from the course. So how it was achieved was that the aim from the start of the partnership was to achieve sustainability and to be able to enable transfer of the program to the local universities. And it was, the intervention part of it was blended online and face-to-face learning with the use of assignments. Intensive learning was used to ensure that staff could plan for learning and assignments, also enabling them to fit the learning and education around their teaching and supervision responsibilities. So the modules and the program was designed as such that the staff could step off the program and receive a certification for their work and education. And they didn't have to complete the full master's program, which has enabled even the busiest staff members to learn and improve their skills during the course. So the approach used was teaching was developed together between the partners, also ensuring that the Somaliland context was in mind. And 55 volunteers contributed to the total of the delivery of the courses, volunteering around 2,070 hours of their time. So what was achieved, the impact that was achieved was that 68% of the teachers felt better with their teaching, 90% of the faculties at all 3 Somaliland universities studied the PhD HPE program, 55% of the staff improved their assessment and evaluation skills, and 100% reported to be better at planning of their lessons. Also, 100% of the staff reported improved overall teaching practice. So the way that the health professional education masters was designed, it was also so that module 1, 2, 3, and 4 gave you the certificate level. The 5th, 6th, and 7th module gave the staff member diploma level, and module 8, which was the dissertation module, qualified them for a master's in health professionals education. Thank you so much. That was my presentation, and I hope to be able to answer any of your questions or comments later. Thank you.
Thank you. Over to you, Aster. Aster, over to you.
Thank you, Jama, for the very nice presentation. Then the next speaker will be Bekalu. Bekalu, are you there? So Bekalu, you will have 5 minutes, and then the Q&A will follow at the end of all presentations. I am Aster from Ethiopia, Addis Ababa University. Just to introduce my name, thanks. Bekalu, briefly introduce yourself, please.
Thank you, Dr. Aster. I'm Bekalu. I'm the Digital Learning Technical Lead for the Health Workforce Improvement Program. I'm from Amref Health Africa, but I'm based in Jama. So, as we all know, I will be presenting on expanding access to digital learning avenue to enhance the competency of health workforce in Ethiopia. Starting from the first report of the COVID-19, most of our activities has been disrupted by the case of this pandemic, and we have been forced to use technology to work on the everyday. Our work and education is not that is different, which has been also affected. So we have been forced to adapt technology in this COVID era. And this digital learning is not pacing itself with the evolving need of educations, and we have been working closely with the different higher education institutions, where we have seen a gap in terms of awareness in the use of technology and our lack of digital skills, and there is poor coordinations and planning related to technology, and even we have observed that there is inefficiency of using the existing digital technologies at those higher education institutions. So with this, we have planned to support the ministry, the higher education institutions, and the professional associations to best utilize the existing technology and reinitiate the teaching learning process that has been disrupted through this COVID pandemic. We have approached it in different ways. We have been supporting the ministries and the higher education institutions to develop and convert different electronic courses. We have been also identifying different open source technologies that could be used to enhance the teaching learning process. And we have also conducted a number of capacity building so that they could sustain themselves through the mentoring coaching process that we have been engaged with those higher education institutions. And from this, we have converted close to 7 electronic courses. And out of those 7 courses, 4 of them are CPD, continuing professional related courses that focuses on malaria case management, respectful maternity care, quality improvement, and hypertensive disorder in pregnancy, and 3 pedagogical courses for faculties that will allow them to develop and deliver different online courses like e-course design and development, instructional design, and an item writing skill course. And we have delivered this basically 2 courses, the instructional design and the e-course design and development, on the Ethiopian Ministry of Science and Higher Education platform. We have enrolled close to 93 participants across 22 higher education institutions and 4 professional associations. And from this, 46.2% of them have completed the instructional design course, and 29.62% of them completed the e-course design and development. And again, through the support of implementing different open source applications to enhance the teaching learning process, we have implemented a digital library for 3 higher education institutions to create an opportunity for faculties and students to avail different educational resources. And we have provided capacity building for 21 library and IT staffs. And also to best utilize the existing simulation centers where it has also affected by the COVID as well. So we need to have a strong scheduling system with the inventory management for managing all the resources existing in the simulation center. And we have implemented in 2 higher education institutions and trained faculties, simulation center assistants, clinical coordinators, or close to 26 individuals. These have created the opportunity for the academic leaders to identify which departments are better utilizing those simulation centers and which skill mix has been trained for their faculties and for students so that they could monitor the implementation of the curriculum. With that, we have seen that it has created an access and as well improved the quality and equity of health professional education and training. And it has also enabled the healthcare provider located in local area to get access to courses where they could develop their competency at lower cost, and including the faculty development where we have reached more than like 22 higher education institutions. And also we have observed that it has a potential to improve the use of educational resource like the simulation center, where there have been a challenge in improving the utilization service at the higher education institutions. And now we are thinking of expanding these solutions to the higher education institutions and as well improving, like supporting the academic leaders to get on understanding the awareness and the importance of distance learning solutions so that they could support the implementations, and as well to measure the effectiveness of this digital learning solution so that they could best scale to other higher education institutions as well. Thank you. Back to you.
Thank you, Bekalu. This is an excellent presentation in the area of COVID, utilizing digitization. And the next speaker will be, do we have Laini or Gaturu? Yes, I see you.
Yes, I'm here.
Okay, thank you. Could you please share your slide? And you have 5 minutes, please.
Okay. I don't know if it's visible to everyone.
Yes.
It is. Okay, thank you very much. My name is Lynn Modhoni Gadhuru. I'm a radiologist. I'm currently working at a hospital called Thika Level 5 in Kenya. So the title of my poster is an analysis of registered radiological equipment in Kenya. On the background, radiology plays a key role in healthcare. However, despite this, there is marked disparities in the availability of radiological equipment, with the majority of those affected living in low and middle income countries. This is in comparison to high income countries where this equipment is readily available. And this has been previously termed in other studies as the radiological divide. Proper planning of healthcare requires accurate and robust data. However, despite this, there is paucity of data on radiological equipment, especially in the African setting. And this is what motivated us to carry out this study, which is an in-depth analysis of the registered equipment in Kenya, which is a lower middle income African country, and then compare the findings to published international data. So what we did is we obtained data on the radiological equipment from KENRA, which is the Kenya Nuclear Regulatory Authority. And then you obtained information on the population from the national census carried out in 2019. We then analyzed our data in terms of number of units of equipment per million of the population, and we analyzed it in terms of the imaging modalities, the healthcare sector, which included private and public healthcare sectors, and administrative units, which in Kenya included regions and counties. We then compared our findings to published international data, including data from Tanzania, Zimbabwe, South Africa, Zambia, Uganda, and the OECD countries. So on our results, what we saw was that X-ray was the most available imaging resource in Kenya at 24.5 units per million of the population. This was followed by CT scan at 3.9 units per million. PET-CT was the least resource at 0.02 units per million, and it was observed that PET-CTs are currently only available in the private sector. in Kenya. We also noted that there is an overall increase in the numbers of equipment from 2013, where we had 20 units for X-ray, 0.8 units for CT scan, and 0.5 units for mammography. It was also observed that the majority of the equipment in the country belongs to the private sector. And for example, for X-rays, the private sector had 86.2 units per million of the population, which was about 9 times higher than the public sector at 9.4 units per million of the population. And this was also lower than a half of the WHO recommendation of 20 units of X-ray per million of the population. So comparing the resources for our public sector to the different published African countries, we observed that the facilities for CT scan, fluoroscopy, and mammography closely mirrored that of South Africa. However, for X-ray, the resources in Kenya were lower than that of Zimbabwe, South Africa, and Zambia, which were all lower than the WHO recommendation of 20 units per million. We also noted that of the 6 African countries, PET-CT scanners are only available in the public sector in South Africa. So in conclusion, we observed an increased number of equipment and homogeneous distribution throughout the country, and we largely attributed this to a scheme known as the Managed Equipment Services Scheme, which was introduced by the national government of Kenya in the year 2016 to ensure equitable distribution of resources in the public hospitals. We recommend that more needs to be done regarding equipping X-rays and PET-CT scanners in the public sector. Thank you. Thank you.
Thank you so much, Lenny. This is a wonderful presentation. Do we have Tsion? Are you there?
Yes.
Could you please share this slide? Okay, thanks.
Okay, I have.
Tsion, you'll have 5 minutes, please.
Thank you, Dr. Aster. This is Tsion from Ethiopia. I'm working as Senior Pre-Service Education Advisor for JAPA. My title of presentation is Technology Assisted Learning and Collaboration to Improve the Implementation of Competency-Based Curriculum. This is the experience from having a spoken institutional network. As you know, competency-based curriculum is recently implemented in Ethiopia. However, the implementation is optimal, especially to address gaps on leadership, gender, and digital technology. In addition to this, institutional networking and peer learning is not also well developed to address different issues. As a result, USD-funded Health Workforce Improvement Program introduced a virtual hub-and-spoke learning and collaboration among higher education institutions. As intervention, the project established a virtual hub-and-spoke learning and collaboration network among 42 higher education institutions in a cluster of 4. In due course, orientation was provided on tools and processes we follow with this hub-and-spoke networking. To make the hub-and-spoke networking standardized, a 6-month curriculum was designed and introduced to the hub-and-spoke institutions. In addition to this, capacity of the institutions were built on case writing and virtual facilitation. The key accomplishments are, over the last 3 months, we conducted 9 virtual sessions, and these sessions attracted around 377 faculties from 42 institutions in a cluster of 4. The main topics covered with these 9 hub-and-spoke sessions were academic leadership. This academic leadership, the experience of Hawassa and Haromaya University were shared among their respective spoke universities. The students' performance assessment, the experience from Addis Ababa and Hawassa University were shared. On digital, on skill development lab, the experience from Hawassa and Woretaw University were shared among their specific spoke universities. In relation with digital learning, the experience from Jama and Hawassa University were also shared to their spoke universities to introduce teaching and learning process and also to strengthen digital learning solution as system approach, especially on improving issues related to registrar. On quality improvement, the experience from Woretaw University were shared among spoke universities, and these sessions were very instrumental to build capacity and to encourage peer-to-peer learning. From this, the project has learned as this having the spoke sessions facilitate institutional experience sharing and professional network to improve the pre-service education. Experiential and or case-based learning are also very powerful because they are based on practice and real-world life than the theoretical learning. They are also cost-effective because they save time as well as resources because we don't need to move faculties from one place to the other. The other thing, this approach opens the door for faculty and experts to know each other, and they started to share experts from one institution to the other institutions. So we have learned as this approach is very informative to encourage peer-to-peer learning and to build the local capacity from the experience and from the resources they have. Thank you so much.
Thank you, Dr. Tsion. It was an excellent presentation. Back to the, I think we have finished all the presentations. Alima, could you please advise us if you have finished all the presenters? Do we have Felix, Ebenezer?
Yes, so Ebenezer has still not logged in, so we don't have him, but Felix is not coming.
Okay.
Felix said he can't make it.
Okay. In that case, Nitabi, can you summarize the first presenters and then I go for the next?
Okay. Well, let me thank the presenters for the nice presentations. I have some questions for each one of them, though. You presented, you gave a very good presentation, Alemseged, about accreditation, how it improves quality, and how you had a high-level advocacy with primary stakeholders, and you know how you also developed implementation guidelines, especially for medicine, nursing, midwifery, and anesthesia. I just wanted to find out from you, how has this also, just note the question, how has this influenced the regulatory body in terms of developing an act? Are you regulated by, all these professions regulated by one body, or do you have different professional bodies? That was for Alemseged. And I'll go try to summarize Asselef: investment in addressing gender disparity to improve health professions education. Another great presentation that was made. And I just wanted also to find out, it is an important presentation or study, which profession amongst the health professions are most, are experiencing the most disparity. I know this is a big issue, and I just want to find out which one is most affected and what is, I've seen what is being done, but for that particular or those particular groups, what is actually happening there. And then I also had, I should not forget the
Jama?
name.
Jama?
Yes, Jama, who was also had another nice presentation of transferring of a health professions education cost to local partners, which is really a very good presentation involving local people and all the other stakeholders. I just wanted to know how then has it improved your collaboration with the local partners in terms of practice, you get problems trying to find clinical placement for students, but when we have involved them in such an activity, it would be interesting just to find out how, you know, that also pans out when it comes to that. So those are, you know, in terms of higher education, I think this is really great that you are addressing these issues and also making sure that our products when they graduate are high quality graduates. Thank you very much for the presentations that you made, and I wish you well. Back to you. You know, before Aster comes in, can we have the responses?
Yes, sure. Let
And
him respond.
ask as well.
Yeah.
So can I go first? Because the first question was for me.
Yeah.
Yeah, sure.
Thank you, Phaladze, for the important question. Our regulatory agency is just one for every field of study, engineering, agriculture, wherever. So what we are trying to do is we, through our engagement and alliance with the professional associations, we are trying to clarify for our regulatory agency how important professional-led regulation is. And we are lobbying for a delegation or probably to kind of change, as you said, the act or the proclamation so that we do have health professional councils taking care of the technical aspects of accreditation. So recently, actually, there is now people are working on it. They are trying to make it autonomous, more autonomous, and hopefully it will give us a delegation. There are a lot of things going on. We have a health professional council on the pipeline. We have a draft proclamation awaiting endorsement from government officials. So I am very much positive going forward, either we get the delegation or the entire thing when it comes to accreditation of health science programs to professional-led organizations like the Health Professionals Council that we are trying to establish.
Oh, great. Wonderful. Wonderful. Mm-hmm. Thank you.
All right.
I had also asked Asselef a question.
Okay, thank you. The most affected disciplines in terms of gender disparity it differs a little bit because nowadays, because of the different gender activities, there is a mixed results among professionals, but when we see the general workforce disparity in gender, for example, in the last 5 years, it shows doctor represented only 23%, anesthesia, medical laboratory, medical radiology, they are represented 28%, 26%, and 36% respectively. But when we see in the education sector, for example, like nursing, the disparity is now a little bit good. And also in the midwifery, in the education sector, as well as in the health workforce, the general workforce, it is good. But generally, there is a gender disparity among medical doctors and medical radiology, and in fact, in anesthesia also. Thank you.
Thank you. And I think I have a question for Jama.
Jama, are you there?
Or maybe he has gone.
Let me check if she's. I don't see her in the list. Maybe she is disconnected. In that case, shall we continue with the other group?
Sure.
Okay.
Thank you.
Maybe before I go for summarizing and forwarding my questions, I have seen in the Q&A, Martin, I don't know if Martin is still connected. There is a question for, I see Martin is there. So there is a question, what about MRI? I think this is for the radiology equipment presentation by Laini from Kenya. Laini, you may answer this question together with any other question that could arise. So having said this, I will start with Bekalu. I think COVID, we could also say blessing in disguise that we're starting using ICT technologies. Maybe Bekalu, one of the things, I wish we could sustain this after COVID is over, at least in a hybrid form, and also to utilize expertise, be it within country or with international collaboration, as we have seen with Jama's presentation. So Bekalu, any major bottleneck that you noticed, if we really act on it, could solve other problems. And I would also encourage the audience in this webinar to forward your questions in the Q&A chat, please. This is for Bekalu. I think the next one is for Laini. Having this equipment database, as you said, is really great, not only to know where is what, and the improvement that we have seen in Kenya is also really great. Maybe one of, again, the same question for you. What are the main challenges that you faced during having this database, and what are the main challenges in Kenya? For example, have you ever checked the downtime of these equipments, and anything that we would suggest that could be a lesson for the rest of us too? This is for Laini. Maybe for, I think for Tsion, this is really an excellent lesson that through this virtual platform that you could have experience sharing. And also, what about this digital technology in terms of improving skill-based learnings? I know this mobilizing resource, cost saving, anything that the lesson that you have shared us is really great, but what are its downside regarding skill-based trainings? Thank you all the presenters. Maybe after finishing that, I do have a comment for the previous ones. Alemseged, on accreditation, maybe because I have also heard Natabi asking you whether we do have one regulatory body. This regulatory body here in Ethiopia, those are accrediting diverse specialities. They are using expertise in each field. Whenever they want to accredit, for example, laboratorians, they use laboratorian experts outside the institution. So as also Alemseged said, the Health Professional Council in the long run will take that responsibility, but even now they're using experts. And for the gender presenter, Asselef, yes, the gender disparity issue. Don't we have gender offices in all our, because I'm from the higher education institutions and also an advisory council of the Ministry of Higher Education, Ministry of Science and Higher Education, I know at least all our higher education institutions do have the gender offices. For me, I don't think it is a lack of the gender offices, but do you identify any other gap other than not having these gender offices? Thank you, Asselef. Can you hear me?
Yes, we
Can
can.
we start?
Yes,
Can we start? Because we want to encourage our audiences. Can we start from the question of our audience, Martin, about the MRI service issue in Kenya? Lenny, please.
Okay, thank you very much. On the question of the MRI issue and also the question of the downside and the challenges we faced when we were conducting our study, I'll combine the answer for the two because it's similar. The main challenge we faced was that some equipment were not registered in the KENRA database, which included the MRI and the ultrasound, and we were not in a position to do a physical check in all the hospitals. So as a result of that, we didn't include them in our study. And this has also been found in the studies for these other countries in Africa. So I'd say that is the main lesson we learned, that there is need, especially for ultrasound, which is a basic radiological imaging modality, for the countries to keep their databases up to date and to ensure that they are recorded, to ensure that we get accurate data on radiological equipment. Yeah, I think that is it for the two questions.
Thank you, Laine. Can we proceed with anyone can jump in?
Proceed.
Yes, Bekalu, please.
Okay, thank you, Dr. Esther, for the very nice questions and compliment. So, as we all know, when the COVID arises, one of the main, education has been one of the sectors that has been significantly affected. And during that time, there was no any regulatory and policy framework that supports the implementation of digital learning in the education sector. So with that taken into consideration, Ministry of Science and Higher Education, in collaboration with one of its agency, the Ethiopian Education Research Network, they have developed a policy framework that can be used by the higher education institutions to implement digital learning, and that have alleviated some challenges, the major bottleneck in terms of using technology for education. The other challenges as a bottleneck are the lack of infrastructure that could be used to facilitate the teaching learning process. As we all know, most of the higher education institutions, they don't have even the very simple equipments of creating a smart classroom with the basics, projectors and the computer stuff to facilitate the teaching learning process. And also the perceptions and lack of the digital skills exist between the professionals, the educators, as well the lack of awareness and understanding from the academic leaders to support the implementations of technology. And again, as we all know, we have encountered there is a very minimal support that we get from the IT professionals, which they have kind of lack of basic competencies that is needed to support the basic operations of digital learning technology. That have all these have contributed to inefficient use of even the existing resources in the higher education institutions. So these are some of the bottlenecks that we have observed as a major thing across all the higher education institutions.
Thank you. Natabi, how many minutes are we left?
Let me see.
Alima.
We're almost done. Am I right, Alima?
Yeah, we are done. We are out of time, actually.
Yeah, we're out of time.
Yeah.
Okay. I mean, in that case, could we please all acknowledge and thank these excellent presenters, all of you? I don't see Jama, but we applaud for all of you for your excellent presentations. Thank you so much.
Thank you.
Can we have all the presenters?
Great presentation.
Thank you. Can we have the
Thank you so much.
We have to have the pictures. Unfortunately, my video cannot open so that a picture is taken, isn't it, Alima and Edward?
Yes, please. We want to take a picture.
Yeah. Can you open our videos if you can? Mine is not working, but try. At times it works.
Yeah, it has been deactivated, I mean, the video.
Yeah.
So how are we going to take the picture?
Someone activate the video from Oluremi. How about
let
me make you all cohort.
Here it's working. Try it again, please.
Video አልከፍትልኛል. Video.
Now it works. Please try it.
Mine doesn't work, but others can have their video on so that you take those pictures.
Yeah, if you
I
can't
can
turn on your
see
video, I'm just yeah, that's great. That's great.
ጃፓይኮች እንዴት ነው የከፈታችሁት?
We can crack, we have hackers. We have hackers.
Now I see, guys.
Is that it? Is that all? Anybody else? Yeah, please turn on your, yeah, that's good. Great.
I think Edward is allowing us now.
Yeah,
I think so.
Yeah, mine is not functional.
1 minute, let me just
nice to
check.
see you.
Okay, this is perfect.
Yeah.
All right, thank you so much.
Okay, thank you guys.
Thank you.
Thank you.
Bye-bye.
See you soon.
So I guess we can go to the main, can we now go to the main place, Alima and Edward?
Yes.
Let's go to the other section, right? The plenars.
Yeah, that's what I think. So I think that's where we should all go.
Okay, perfect.
Okay, we will.
All right.
Namana